Hello friends, this is about the INICET November held on 13th recall session. So we'll be seeing the obstetric questions. So which among the following is not a method of MTP in first trimester? This is a very easy question and it's a previously asked question. So what are the options that have been given is ethacridin lactate. It is given as extra amniotic installation. Okay, this was the option given. First one is extra amniotic installation misoprostol on methotrexate and DNC. So which among the following is not a method? So there was not a method. So the answer very obvious, that is extra amniotic installation of ethacridin lactate. So coming to the what are the methods under first trimester, you have both the medical method and the surgical method. Under the medical method, what are the drugs used? Mifepristone, misoprostol, methotrexate, and even tamoxifen is used. Okay, not routinely used. What routinely used is mifepristone, misoprostol. Okay, what is surgical methods? Under surgical methods, it is the menstrual regulation, manual vacuum aspiration, suction evacuation, and dilatation and curettage. So all these options are there. Dilatation and curettage was given. So that is one method, manual vacuum aspiration. Another one is misoprostol and methotrexate. So misoprostol and methotrexate. Okay. So all these three things are comes under first trimester. So coming to the first option, extra amniotic ethacridin lactate, it is a second trimester method. Another one which can be given extra amniotic is the prostaglandins. So this is the method from the second trimester. It's a very easy, straightforward question. This table is from Williams, and it's an easy question. I think most of you would have answered this. Coming to this, see, this is also kind of a easy question. We know that vulval cancer are more common in the postmenopausal age group. So here, coming to the options, it is 35 to 65. See, 35, it's vulval cancer itself is a rare cancer, uncommon cancer. And it occurs predominantly in the postmenopausal age group. The median age is 60 years. So the first option is a very wide range of 35 to 65. Obviously, this is not going to be your option. The next option is 55 to 85. That is going to be the right option, and it's the most apt, right? 55 to 85. So other options are ruled out. Okay. So this is an easier question again. Even if you don't know what is about the vulval cancer, one thing, it's very easy. It's postmenopausal age group. With that, you could have answered this. It's an easier question, actually. It's an uncommon tumor which contributes to 3 to 5% of gynecological malignancy. It's the most common in the postmenopausal, that is 55 to 60s. And if you have to say the median or the average, just 60 years. Most common, what are the other questions we can expect? This is for the benefit of other students. Okay, the most common variety is 90% of them are squamous cell carcinoma. And what is the most common symptom they present with? Pruritus. Okay, it is not bleeding, it is pruritus. The most common site is the labia majora and minora. The first option will be majora. Okay, the most common route of spread is by the lymphatics, and the most important prognostic factor is the lymph node status. This is a very interesting question. Teratogenic drugs, it's previously asked question. It's a easy question, actually. If you know this, it's easier. So what does it cause? Warfarin, it causes a depressed nasal bone. So warfarin is depressed nasal bone. Thalidomide, phecomalia. Okay, what is phecomalia? It is limb deformity. Phecomalia is limb deformity. Lithium, very classic. It causes Epstein anomaly, cardiovascular system, Epstein anomaly. Chloramphenicol, very, very easy. We know this. It is a gray baby syndrome. So lithium, it causes a depressed nasal bone. Thalidomide phecomalia, which is a limb deformity. Lithium causes Epstein anomaly. Chloramphenicol leads to gray baby syndrome. Coming to the next question. Not a part of biophysical profile. Again, this is a easy question. So answer is DFMC. What is DFMC? Daily fetal monitoring count. Okay, daily fetal count. So what are the components of biophysical profile? So you have two things. One is the biophysical profile. Another one is the modified biophysical profile that is being followed now. Okay. Coming under biophysical profile, it's also called the Manning score. This can also be a direct one-liner, which includes the fetal gross body movement, fetal breathing movement, fetal tone, amniotic fluid volume, and the NST. So under component, they have been described. How are you giving the scores for this? Components. So score 2 is given if the fetal gross body movement of more than 3 discrete body or the limb movement, you give a score of 2. The score of 0 is given if it is less than 3 discrete movements. Coming to the fetal breathing movement, if you have more than or equal to 1 rhythmic movement which is lasting for more than or equal to 30 seconds, you give a score of 2, and you give a score of 0 if it's less than 30 seconds of breathing. Coming to the fetal tone, if you have more than 1 extremity extension and it has to return to the flexion, and there is if you give a score of 0 if there is extension or there is no extension or flexion events, then you give a score of 0. Coming to the amniotic fluid volume, the pocket of the amniotic fluid volume measures at least 2 centimeter in the two perpendicular to each other. So it should be at least 2 centimeter. And deepest single vertical pocket, if it's less than 2 centimeter, less than or equal to 2 centimeter, you give a score of 0. NST, if you have more than or equal to 2 accelerations within 20 to 40 minutes, you give a score of 0 if it is 0 or 1 within 20 to 40 minutes. So highest score is 10 and lowest score is 0 or 2. Modified biophysical profile, which includes the NST and the amniotic fluid volume. This is a screening test performed for 10 minutes and it is also comparable to the classical biophysical profile. Normal is NST is reactive with the AFI of more than 5 centimeter. It is not equal to, it is more than 5 centimeter. When it is said to be abnormal, when it is non-reactive, NST is non-reactive, or the AFI is less than or equal to 5 centimeter. Okay, this is about the biophysical profile. This is again a very easy previously asked question. Coming to the next question is the minimum number of antenatal visits. Again, this is a previously asked question. What is the change here is, see, as far as I got it from the students, I couldn't clearly get whether they have asked whether it is a WHO or they normally ask for an Indian scenario. Okay. Why is that is, see, WHO previously in 2016, they have come up with WHO ANC model where they have brought certain changes in the antenatal visits. Okay, in case of antenatal care, what they have scheduled, see, previous model says it calls for the which consists of the 4 visits. The recent one of the 2016 which says it is 8. Okay, so it's a minimum of 8 visits, minimum number of 8 visits, that is according to the WHO. This will reduce the perinatal mortality. And what are the other changes they have mentioned? Instead of saying it's a visits, they say it's a contact. The contact between the patient and the healthcare worker will reduce the number of mortalities, both the perinatal and the maternal mortality, and there is an early detection of high risk pregnancies. Okay, so this is what a change. So the question is, if it is WHO, the minimum number of visit will be 8. If it's in a clinical scenario, in a Indian scenario, it should be 4. Okay, that's what is classically followed. So the option for this, if I go with, they would have asked WHO. Assuming it is WHO, I give an answer as 8. Okay. If they would have asked what is only the minimum number of antenatal visits, not mentioning anything, WHO, the answer will be 4. Okay. This is again a very easy question. There's a lot of, they always ask a question from magnesium sulfate. One another type of questions are framed from magnesium sulfate from INICET. So this time the question is relatively easier. The first sign of magnesium sulfate toxicity, the answer is loss of knee reflex, or the loss of deep tendon reflex, to be more apt. What are the other things we will see? Overall, we will see the therapeutic dose. See, therapeutic dose is always a very, very important question. They can ask you in different things. Like a mini equivalent, it is 4 to 7 milli equivalent per liter. In milligram per deciliter is 4.8 to 8.4. Come in a millimoles per liter, it is 2 to 3.5 is the therapeutic dosage. When you start a magnesium sulfate, there is monitoring. What do you monitor? One is the patellar reflex or deep tendon reflex. Another one is a urine output, respiratory rate, saturation. All these are the things you monitor. All this can be a direct question. How is the toxicity presented? The first thing to disappear, the toxicity, the first sign of toxicity is the loss of the deep tendon reflex. That is seen when the magnesium sulfate value reaches up to 10 milli equivalents. What is the management? Withheld a dose and restart it once it returns. So that was going to be your management. Coming to the urine output, when there is low urine output, which is reflected as an increase in serum creatinine level, then what is the management? The next IM dose decreased to 2.5 grams. So that is going to be the management. Coming to the respiratory rate, normally more than or equal to 16 with a saturation maintaining or more than or equal to 96%. When does the respiratory depression occur? If it is 12 milli equivalent, there is respiratory depression. Okay. When there is more than 15 milli equivalent, there is respiratory arrest. In case of a respiratory depression, you give an antidote. How will you manage this? In a depression, you give an antidote of 10% calcium gluconate or calcium chloride, 1 gram IV. In case of a respiratory arrest, you have to intubate the patient. When do you get a cardiac arrest? If the magnesium serum levels increases more than or equal to 30 milli equivalents, leads to cardiovascular cardiac arrest, and you have to intubate and resuscitate the patient. Another very, very important question they always ask from magnesium sulfate is, well, till when you have to continue this magnesium sulfate? If the seizures occurred before delivery, you continue it 24 hours after delivery. If the seizures occurred after delivering the baby, she develops a seizure, you give 24 hours after her last seizures. So that's important question they usually ask from magnesium sulfate. This is again a very, very, very easy question, straightforward question. It's a long-term reversible method of contraception. It is also called as LARC, long-term reversible contraception. Under these things, what are the things you have? One is the implant. Another one is the injectables. Depot injectables you have. Another very important thing is copper T. This is non-hormonal. Under the hormonal, you have the intrauterine contraceptive device. To be more specific, it is the Mirena. So this is a very easy, again, from a contraception. They have asked a very easy question. It's a straightforward question. So answer here is sterilization. So B will be the option. Coming to this, protein hormone secreted from placenta except. So it's a very easy question. Again, it's HCG. Is the hormone, the protein hormone that is secreted from placenta. See, there's been a lot of questions they've asked from placenta. It's good that they're asking a lot of questions from a basics. I think many could answer this question easily. See, LH, FSH, GnRH, you know where it is produced. from where it is secreted. So placenta secretes HCG. What are the other hormones that is secreted by the placenta? Progesterone, estrogen, human placental lactogen, human chorionic gonadotrophin. That's what the option they have given. Another one is human chorionic thyrotrophin. Another very important thing to remember is PAPPA, that is protein associated plasma protein A. Okay, these are the hormones that are secreted by the placenta. Another question, as I told, it's asked from placenta, and this is a very easy question actually. Look at this, the option is so obvious. The answer is the placenta with two vessels. We know the umbilical cord contains three vessels, two arteries, one vein. How to remember these three vessels? Single umbilical artery is a abnormality, as we know that. Okay. If you know this, you remember there will be two arteries, one vein. If one artery, it's an anomaly. If it's two artery and one vein is a normal one. Coming to the other options, it weighs 500 grams at term. Yes. Diameter, it ranges from 15 to 20. They say they have given as 22. That's okay. Oval in shape, or you can say circular disc, is the more apt word to describe a placenta. But the obvious answer, which is not seen in a normal placenta, is a placenta with two vessels. What are the other questions they can ask from normal placenta? See, placenta is a discoid, deciduate, hemochoroidal structure. The weight of the placenta at term is 500 grams. The ratio of weight of placenta to the fetus is 1:6. It's a very important one-liner. The weight of the placenta will be equal to the weight of fetus at 17 weeks. That is also a question, direct question, which can be a future questions. Diameter is 15 to 20 centimeter. Thickness at the center is 3 centimeters. Coming to its surfaces, there are two surfaces, the maternal surface and the fetal surface. Maternal surface, which is a dull red and rough, which contains lobes of 10 to 38, and the cotyledon is a functional unit of the placenta. This maternal surface is formed by the decidua basalis, and the line of separation, the placenta separates after the delivery of the baby. The line of separation is the spongiosum. Decidua spongiosum. Nita-Bush layer that you have to remember, that is seen in the outer syncytial trophoblast. Okay. And Hauber cells, these are found in the stroma of the placenta. What are these? These are the fetal macrophages. Coming to the fetal cell surface, which is a shiny gray in color, which is covered by amnion and is formed by umbilical cord. This is what they've asked. They consist of three vessels, as we have already seen, two arteries and one vein. Again, this is also a very easy question. It's a definition for primary amenorrhea. How could you define a primary amenorrhea? A girl presents with amenorrhea, not attained menarche with age, and breast tanner staging off. So how do you define it? See, primary amenorrhea is defined as 13 years. A female, she's 13 years without any sexual characteristics, or she's 15 years with sexual characteristics. See, what I've given in the bracket, this was a previously defined. So it is important that it has changed. The new one says it is 13 years without sexual characteristics, 15 years with sexual characteristics. This is a Tanner staging, which consists of 5 stages. Okay, so according to this definition, the most apt option or the answer will be yes, age 14 years with the Tanner stage 1. Okay, 12 years stage 4 is a well-developed breast. Okay, again 13.5 is a well-developed breast. So this is ruled out. So okay, 11 years is not age is not a criteria here. See, 11 Tanner stage 1, again, it should be at least 13 years. 13 is not somewhere, it's 2 years less. So more apt, somewhere near is 14 years. So we'll take age 14 with Tanner stage 1. Okay. Which amongst the following is wrong regarding late deceleration? I think this was, for some people, it will be a slightly difficult one. Yes, it's kind of difficult. Um, we'll see. But if you know the basis or the concept of this deceleration, it's easy. So late decelerations, these are smooth, gradual, symmetrical decline in fetal heart rate. Okay, it begins at the contraction peak and returns to baseline only after the contraction ends. That is important. And the nadir is within the 30 seconds of it onset, and typical depth is 10 to 20 beats per minute, which is below the baseline. And usually it is not accompanied by any acceleration. So these are the features of late decelerations. Okay, decelerations can be of early deceleration, late deceleration, variable deceleration. When I say early, it coincides with the contraction. See, it coincides. This is a contraction. This is a fetal heart rate. Okay, so it coincides with the contraction. It is the early deceleration. What is the cause? Remember, head. Okay, head compression will lead to early deceleration. That is a normal phenomenon. You need not rush for these things. Late deceleration. What is late deceleration? As we say, it is late. It can be at or after the contraction peak. So after a contraction, there is late deceleration. After the contraction, you can see there is decline in the fetal heart rate. This is because of the placental insufficiency, uteroplacental insufficiency. So that is about the late decelerations. Coming to variable deceleration, it is variable with contraction. So it's simple. Variable is variable with contraction. So what is the cause? It is umbilical cord compression leads to variable decelerations. So now coming to a question. They are small, smooth and gradual. Yes, that's a true one. Start after the uterine contraction starts and ends after the uterine contraction ends. So this is one thing sounds to be wrong. The fall in the heart rate is more than 10 beats above the baseline. So what have I said? It's typical depth. What you see is 10 to 20 beats per minute below the baseline. Not followed by any acceleration. Yes, that is true. Among these two, which will be the option? Start after the uterine contraction starts. What does it say? Begins at the contraction peak and returns to baseline after the contraction ends. Okay, this is also a right option. The wrong option is the fall in heart rate is more than 10 to 20 beats above the baseline. See, it is below the baseline. Okay, that is the deceleration is decelerating. It's below the baseline. It's not above the baseline. It should be below the baseline. So these, if you little concentrate on this, it is again, if you know, concentrate on the options, it is kind of easier. You can answer this question. Okay, this is all are causes of uterine dysfunction. See, this is again, I myself had a lot of confusion for this uterine dysfunction. What are they trying to ask? So basically, they are trying to ask, this is a direct question from Williams. Okay, this is from Williams 26th edition. Direct question, which is for page number 433. They have given a table for this, a uterine dysfunction, causes of uterine dysfunction. Initially, I thought this is going to be a neuroaxial blockade, which is also called the epidural, will be the option, but this is a direct question from Williams. We'll see what is the option for this. So the causes for uterine dysfunction, here they've asked us, see, they have asked for intrapartum findings. Choriamnitis is a cause, neuroaxial analgesia is a cause, nulliparity. So what I've given in the option was multiparity. So nulliparity is a cause. Another question they've asked is about high station. Yes, high station. So they've asked a question from intrapartum findings. If it is a hydromnius, chorionitis, neuroaxial analgesia, high station at the onset, or the poor maternal pushing or sedation, severe pain, neurological disease, all these can lead to uterine dysfunction. Under maternal characteristics, they have told it is about the nulliparity. The answer, so the answer here will be multiparity will be the answer. Okay, this is again something newly added from the Williams. So they've asked as a question here. This is again normally question, which is the wrong statement related to the period of gestation. So period of gestation is calculated from the last day of the menstrual cycle, LMP. It is not the last day, it is the first day. Okay, first day. Okay. The first trimester ultrasound is the best to assessment of period of gestation. Yes, it is the crown rump length that is used for the assessment of the period of gestation. In an IVF pregnancy, the date of ET, embryo transfer, is needed to calculate the period of gestation. Of course, that is the right option. Yes, embryo transfer date is required to calculate, where you add 38 weeks to the embryo transfer date, or you add 9 months minus 7 days to get the period of gestation. So the option here will be option A, which is the last day it is given. It is not the last day, it is going to be the first day of your last menstrual period. The fourth option is again, it's a incomplete question. Yes, but the answer here will be the option A. This is a direct question. Diethyl stilbestrol causes an increased risk of what cancer? It leads to clear cell vaginal carcinoma. Okay, this is a previously asked question, so I'm not going to explain much about it. This is it's about a procedure. It's a good, they ask this kind of questions. What is the correct sequence for performing a dilatation and curettage? It's simple. First you assess the uterine size and direction, only then you will start inserting any instrument. So this is important. So this is going to be the first assessment of the uterine size and direction. The second will be on the uterine sounding. So you will uterine sound to see its length, then you will dilate the cervix, then do a curettage. So this is the correct sequence for performing a dilatation and curettage. This is again a straight previously asked, usually asked question. Which are the branches of posterior internal iliac artery? So coming to internal iliac artery, it's a very beautiful picture from the this is abused. It's a very easier way to remember. So you have here is the internal iliac artery. So internal iliac artery dividing into, this is anterior. Okay, and we are going to talk about only the posterior division. Okay, under the posterior division, you have first one, it gives the iliolumbar artery and goes along, it gives the lateral sacral artery, and the last one is the superior gluteal artery. So these are the branches of the posterior division of internal iliac artery. So the iliolumbar, lateral sacral, superior gluteal. So the option D will be the see, actually it is, the question should be not a branch of a internal iliac artery, which is not a branch of posterior division of internal iliac artery. The option will be answer D. Again, the question, I think I have made some mistake. It is not a branch of posterior division of internal iliac artery. So option will be the whatever last option they would have given. Okay. Now coming, that was the questions that I could collect from the obs and gynae from morning session. Now coming to the evening session. So evening session was kind of scenarios, case scenarios, some new questions. Some people would have felt it is little difficult. but it's okay. It is not that difficult comparing to the previous papers. Now coming to the question. She's 35 weeks, primary gravida. She presents with a BP of 170, 110, complains of abdominal pain and blurring of vision. Okay. The uterus is contracting, heart rate is 140, she is 2 centimeter dilated and 50% effaced. What is the best management? So first, coming to the before management, you have to understand what is the diagnosis here. What is the diagnosis? Her BP here, it is 170 by 110 with the blurring of vision. So you have a higher BP with a imminent symptom which points towards severe preeclampsia. So severe preeclampsia, what will be the treatment? She has to receive magnesium sulfate. Obviously, she has to receive an antihypertensive, and it's very important you terminate the pregnancy. Why do you terminate? The main culprit for the all the etiology or the severity or whatever, the management should be termination where the placenta comes out. So the main culprit for all the pathology will be the placenta. Once the placenta comes out, the chances of developing eclampsia or other complication decreases. So the option will be termination. So without seeing other options, straightforward, it is antihypertensives, magnesium sulfate, and termination will be the answer. This is again a very easy question. What is arranged in a current sequence of performing an active management of third stage of labor? So the check if there is any other baby is present or not. Okay, that is what they've given option. Okay. Next is about what do we give? Uterotonics, control contraction, and uterine massage. See, active management of third stage of labor, it starts from the expulsion of placenta after the delivery of baby. The average time taken is 15 to 20 minutes. Okay. More than 30 minutes said to be prolonged active management, prolonged third stage of labor. Prolonged third stage of labor. Wonder what are the components? It's the use of oxytocin after the birth of the baby, where you give 10 units IM. Delayed cord clamping, which is from stoppage of pulsation, or it can be up to 3 minutes. Or it can be still stoppage of pulsations. Okay. Delivery of placenta by controlled contraction. See, they have given in the option uterine massage, but according to the recent WHO guidelines, they say intermittent uterine assessment and uterine massage has been taken out as a component. Now, it's uterine massage is not a part of this latest WHO guidelines, since they've asked in question, and previously this was also included. So we are keeping that as fourth option. So it's easier. Again, this is a very easy question. Yes. Anemia Mukt Bharat. This is a very important question. So why this is kind of expected kind of question. This is, but they've asked what is the treatment for the primary gravida of 34 weeks with a mild to moderate anemia. This I'll be little explaining it. There'll be a lot of questions future also, there'll be a lot of questions from this. The option here is injection FCM if not tolerating oral. What is the treatment? So option here is not tolerating 34 weeks with mild to moderate anemia, injection FCM if not tolerating oral iron will be the more apt answer for this. The fourth option I don't know, so leaving that, I think the option A will be the right one. So under this Anemia Mukt Bharat, which is by the Ministry of Health and Family Welfare and UNICEF, have launched this program in 2018 to reduce the prevalence of anemia in all over India. This has a strategy of 6 cross 6 cross 6. See, there are 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. So who are the 6 beneficiaries? The children. 6 to 59 months, adolescent boys and girls, the women of reproductive age, the pregnant women, and the lactating women. These are the 6 beneficiaries under this um, Anemia Mukt Bharat. What does they say? I will just crossly tell which is important from the OBG point of view. See, prophylactic iron folic acid supplementation. I'm talking only about pregnancy. What do they say in pregnancy is daily you give one iron and folic acid tablet. You start from the 4th month of pregnancy, continue it throughout pregnancy, and minimum of 180 days during pregnancy. That is a direct, this can be asked as a direct one liners. Okay, and to be continued for 180 days postpartum. And each tablet, talking about, what did they say, one iron and one folic acid. So one iron tablet contains 60 milligram of elemental iron, and the folic acid contains 500 microgram of folic acid, should be sugar coated and red in color. That is about the folic acid. Okay, this is about the iron and folic acid, prophylactic iron and folic acid supplementation. Another thing they're talking about is the deworming. They say one dose of 400 milligram of albendazole. They are talking about albendazole, one tablet after the 4th trimester, preferably during the 2nd trimester. That is what they're talking about, the deworming. Coming to the third one, what are they talking about? The intensified year-round behavior change communication campaign. What are they talking here is about, you have to check not only prescribing, it is also to see whether the patient is compliant on taking this oral iron and oral iron, especially an appropriate infant and young child feeding. Okay, and encourage the pregnant women to take iron rich food, protein rich food, and vitamin C rich foods. Okay, and it also promotes the practice of delayed cord clamping by at least 3 minutes or until the cord pulsation ceases, and initiation of breastfeeding within 1 hour of birth. They've asked for mild and moderate anemia. Okay, mild to moderate anemia, that too at 34 weeks. This is from the Anemia Mukt Bharat that is given for the pregnancy. See, we have already discussed, you start with the iron and folic acid, or you can give a parenteral iron, can be considered as a first line of management in pregnant who are detected to be anemic late in the pregnancy, or in whom compliance is likely to be low. So that's it. Late in the pregnancy, they're not mentioned how late. What is the period of gestation? Okay. In another, it is called the Intensified National Iron Plus Initiative. Under that, they say it is 34 weeks. So keeping that in mind, maybe that they have used. And so the option that I have chosen was FCM. They use both iron sucrose and ferricarboxy maltose as a treatment in Anemia Mukt Bharat. Okay. The same thing they're given, but in moderate, here you're giving two tablets you are giving, and the parenteral iron may be considered as a first line. Okay, the same thing. So here, what is the difference that they do is they give two tablets. Here, in a severe anemia, the treatment they give here is the IV iron sucrose or ferricarboxy maltose. Directly, they go to the parenteral iron. Instead of, it's a severe anemia, irrespective of gestation, you go with your parenteral iron. And they have also mentioned about immediate hospitalization, especially if it is in the 3rd trimester of pregnancy. This is about Anemia Mukt Bharat. Next question is non-contraceptive benefits of OCP. Again, it's a very easy question from the contraception topic. So, all are the non-contraceptive benefits of OCPs except. See, OCPs and cancers, it's a very, very, very important questions. Questions lot have been trained from this cancers and OCPs. The cancers, cervical cancer, hepatic adenoma, there is an increases the risk. OCP increase the risk of the cervical and hepatic adenoma. Where what decrease the risk of colon cancer, endometrial. Remember, CEO is a mnemonic that has been used. Colonic cancer, endometrial cancer, and ovarian cancer decreases the risk. It has no effect in case of a GB cancer and hepatocellular cancer. Remember, hepatic adenoma, it's a benign tumor and it increases the risk, whereas hepatocellular cancer, it does not have any effect, OCP. In breast cancer, it is inconclusive. We does not know. There are a lot of studies going on, but still it's inconclusive whether OCPs it increases or decreases, or it does not have any effect on breast cancer. And one thing they found is that it decreases the risk in developing the benign breast diseases. That is very important. What are the other, this one? It causes reduced blood loss, especially used in heavy menstrual bleeding. It regularizes the cycle. That's why it's used in PCODs. It reduces the risk of ectopic, used in the treatment of endometriosis, fibroid, because of the above effect, and improves the bone density. So what is the option here? It reduces the risk of endometrial cancer, reduce the risk of ovarian cancer. That is true. CEO. Okay. Reduces the risk of ectopic pregnancy. Again, this is a right option. The option here will be STDs like HIV. Obviously, OCP. It's a very obvious. STDs like HIV. It cannot prevent. Does not prevent it. Okay. Hormones not involved in the growth of fetus. See, again, this I just got directly from the Williams. It's the option is growth hormone. The Williams says that the growth hormone is not required for the growth of the fetus in utero. But remember, growth hormone is required once the baby is out. Growth hormone is absolutely required, that we know. But intrauterine growth hormone is not a very important hormone. Even in the absence of growth hormone, there is proper growth of the fetus. So very important hormone is insulin growth factor 1, which is similar to the growth hormone, that has a more importance in the growth of the fetus compared to the growth hormone per se. So the option here is growth hormone. This is directly again from the Williams. Okay. This is a very, very easy question. When you have to say there is the under this sexuality topic, this is a very easy question, direct question it is. Young female presenting with amenorrhea, she's short stature. So it is amenorrhea with short stature. Webbed neck, it's easy. It's going towards what? It's when you see webbed neck with a hypoplastic uterus with streak ovaries with FSH increase. What is your diagnosis? Webbed neck, short stature, amenorrhea, hypoplastic streak ovaries, striking features of Turner syndrome. Why it is not with the other things? See, Kalman syndrome, MRKH is absent uterus. That much you have to remember. Here it is hypoplastic uterus, that is again ruled out. Kalman syndrome can also be a direct question. What is this under Kalman syndrome? It's also called the de Mossier syndrome. It's called Kalman syndrome. Defect lies at the level of hypothalamus, where it's at the arcuate nucleus. They present with hypogonadism, anosmia, and color blindness. It's a triad with the primary amenorrhea. Remember, it has a normal height. Normal height. Why is it not AIS, that is androgen insensitivity syndrome? Now coming to that, we'll understand it is of two types. Complete, it can be incomplete. How do they present? Incomplete, it is primary amenorrhea with breast development and stage 4 to 5. That is a well-developed breast. That is secondary sexual characteristics are present here. Well-developed secondary sexual characteristics. And they will have bilateral inguinal hernia on examination that points towards your complete androgen insensitivity. How is it different from incomplete? It's the same thing. Bilateral inguinal hernia with clitoromegaly will point towards your incomplete androgen insensitivity. There's another same or the same as the Turner syndrome. See, Turner syndrome will present with primary amenorrhea, absent or less developed sexual characteristics. What is it different? How is it different? Turner syndrome, height is normal. Okay. And the karyotyping is 46. XX, which Turner syndrome will be seeing in detail. Okay, Turner syndrome, it or Seaver syndrome also contains streak ovaries. Remember, the height is normal and the karyotyping is 46XX. Congenital adrenal hyperplasia, they present with ambiguous genitalia. And there is features of virilization. There is 46XX, heterosexual precocious puberty, clitomegaly, and metabolic abnormalities are seen. Coming to Turner syndrome, as you see, it is hypergonadotrophic hypogonadism. Most common karyotyping here it is 45X0. What are the other mosaics you can see? 46XX, or it can be 45XO, X0, or 46XY. So just remember the most common thing, and it is non-disjunction during the meiosis. What is the striking features here is bilateral streak ovaries, suboptimal estrogen levels. So they present with primary amenorrhea. Secondary sexual characteristics are absent, or even if it's present, it is less developed, decreased height, or to say it is a short stature. That to be more apt. Okay. See, fallopian tube, uterus, cervix, and vagina develops, but it remains infertile. Why? Because the estrogen levels are suboptimal. External genitalia develops, and it is normal because the testosterone is absent. So this is the very important points in Turner syndrome. So what are the clinical features? See, it is a short stature with a webbed neck, low posterior hairline. Coarctation of aorta is a very striking feature again in Turner syndrome. Broad chest and the widely spaced nipples. Cubitus valgus. Pigmented nevi, streak ovaries, infertility, primary amenorrhea, and peripheral lymphedema at birth. These are the striking clinical features of Turner syndrome. See, again, I have given under the neonatal, other puberty, and adult life. Very important thing you have to remember, they have a normal IQ. That is very, very important. What is your treatment? Estrogen replacement therapy. Male Turner syndrome, it's called the Noonan syndrome, which is autosomal dominant. They present with streak gonads. 46XY, this is somatic defect, will resemble same that of a Turner syndrome. How is it different from Turner syndrome? It has a pulmonary valve stenosis and mental retardation is present, which is a most common cardiac anomaly in Turner syndrome. It is the coarctation of aorta, and there is normal IQ in case of a Turner syndrome, when there is a mental retardation in case of Noonan syndrome. Yes, this is a very interesting topic, but for the not at your PG question exam level. This is for the PGs. It is a very interesting topic. Very there are a lot of articles have been published or journals have been published for this. Okay, perimortem cesarean section is nothing but, see, cardiac arrest in pregnancy is a very rare. How rare it is? It is 1 in 12,500 pregnancies. Okay. Whenever there is a cardiac arrest, what they do is, if the when you first you have to remember when is it performed. If it is more than 20 weeks, that's what the guidelines say. If it is more than 20 weeks, if the period of gestation more than 20 weeks, when do you do this? When there is return of spontaneous circulation does not occur within 4 minutes of effective CPR. This is a prerequisite that is required. Return of spontaneous circulation. Return of spontaneous circulation, that is called ROSC, does not occur even after 4 minutes of effective cardiopulmonary resuscitation. Then you do a perimortem cesarean section. Delivery, remember, delivery should be within 5 minutes of cardiac arrest. If you know this background, this answer is easy. Done in the lower uterine segment, done in the upper uterine segment, done in the phalansteal incision, done in the OT. See, you're not going to shift the patient to OT and you waste your time. Wherever she is, you're going to operate her. Done in the lower uterine segment, phalansteal, all this. Okay, all this it's a time consuming. As you know, for emergency surgeries, it is the vertical incision you give, you open. Okay, immediately you start opening. It is done in the upper uterine segment. That will be a little easier and it's faster. So the option here, it is done in the upper uterine segment. Okay, so the background, why do you do this? See, the delivery will maximize the maternal survival and decrease the risk of neurological impairment in the fetus. Okay, this is very important. It maximizes the maternal survival. That is why it is important. Okay, so this is new topic, very interesting topic. But the options given, it sounds, but once you look, it looks scary, but the options are easier. If you understand, if you know the background of this, it's easier. Perimortem cesarean section, it's a kind of a, it's easier to understand what do they mean. Okay, so the option here is the done in the upper uterine segment. Frying a fetus in utero is called as the direct option. It is vaginitis vaginalis. Sorry, vaginitis utrinus. Which is not a risk factor for vulval cancer. It is not a risk factor. Answer is vulval hematoma. It's simple. What are the risk factors for vulval cancer? See, they've asked a lot of questions from vulval cancer. So, vulval vaginal cancer is very, very important topics. Though it is a smaller topic, you can expect a lot of questions from vulval and vaginal cancers. VIN, that is vulvar intraepithelial neoplasia, 2 to 5% of VIN 3 has a chance to progress to a carcinoma vulva. HPV, see, 40% of carcinoma vulva are HPV positive. Among that, 80% are HPV 16. HIV, smoking, like sclerosis, valvular dystrophy. It is a hypertrophic variety, that is thickening of the skin. That is hypertrophic variety valvular dystrophy. Another one is Paget's disease, though it's a rare one. That is also a risk factor for development of vulval cancers. Coming to the next question, that is the image-based question. They've asked an image-based question on fetal procedures. I'm not sure what is the picture. This is just, I have, obviously that is not the same they have asked. Options, what I've got was, some say it is amniocentesis, chordosynthesis, chorionic villus sampling. So I'm not sure on what they have asked. But to understand the basics, amniocentesis is nothing but you take the fluid around the baby, and it is usually done between 16 to 18 weeks. Chordosynthesis is nothing but you take from the umbilical cord, that's why it's called chordosynthesis. It's done after 18 weeks. The chorionic villus sampling, where you take a sample from the placenta, where you take the chorionic villi, and it is done between 11 to 13 weeks. Fetal tissue biopsy, you take it from the fetus. So that is the fetal tissue biopsy. These are the prenatal invasive diagnostic tests. Among these two, among the about things what I've explained, amniocentesis and chorionic villi sampling is the question area. And amniocentesis is done, as already I've told, it's between 16 to 18 weeks. What are the materials that you get? Study material, what you see is the amniocytes, fibroblasts that are present in the amniotic fluid. Under the chorionic villus sampling, which is done typically between 11 to 13 weeks, what is the material that we get is the chorionic villi. As the name says, it is the chorionic villi that is present in the placenta. And the fetal loss in case of amniocentesis is 0.1 to 0.3 percentage. To be very exact, it is 0.2 percentage. So where in chorionic villus sampling, it is 1 to 2 percentage, which is a number higher than that comparing to a amniocentesis. Remember, 2 to 0.2 percentage in amniocentesis, 2 percentage in chorionic villus sampling. Another very important new topic is the cisplatin resistance. Regarding the cisplatin resistance, read the statements below, which is a right one. So resistance is recurrence within 6 months. Partial sensitivity is recurrence within 6 months. Sensitive is recurrence after 12 months. So which among the following statement is right? So first we'll understand what is this uh, uh, cisplatin resistance. Cisplatin is a platinum resistance. It can be paclitaxel, carboplatin, or cisplatin. These are the platinum compounds that are used. What are they talking here? This is seen in the ovarian cancer. This is under the ovarian cancer. Where do you find this? Ovarian cancer. After a primary cytoreductive surgery, you give a chemotherapy. If you give a chemotherapy and there is a recurrence during chemotherapy, if there is recurrence, then it's said to be platinum refractory. Okay, platinum, they are refractory to the platinum compounds. If they develop within 6 months of the chemotherapy, it is said to be resistant. Okay, it develops between, okay, it is developing between 6 to 12 months. It is said to be partially sensitive. If the recurrence occur after 12 months, see, it is after 12 months, it is said to be sensitive. That means it is sensitive to platinum. You still have a possibility of trying another platinum compound, which was not previously used. That's what it simply means. Okay. So this is about the platinum resistance. Keeping this in mind, coming to the options, now we will easier to understand. Resistance is what? Is recurrence within 6 months. Yes, this is a right option. Partial sensitivity is recurrence within 6 months. See, partial sensitivity means it is from 6 months up to the 12th. So anytime between 6 to 12. So that's what to say. Partial sensitivity is recurrence within 6 months. True. I think something is wrong here. I think the option was, I think I have typed it wrongly. The partial sensitivity is the recurrence from after 6 months. Okay, it is after 6 months. That's what I've typed it wrongly. That's what the option given. Sensitive is recurrence after 12 months. This is also a right option. So all the three statements are right. So option here will be all of the above. See, I might be wrong. The options, I'm not clear. I'm not very sure of the options. But what from the students I got was the partial sensitivity is recurrence after 6 months. That is what the option I got. With that statement, it's a true or statement. Okay. Arrange the following steps of mechanism of labor in correct order. So we know that it's engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation. So with that option, you start with your engagement first. Then what will be your next? Engagement will be the first. Then you have the crowning, extension, restitution. That's how it is given. Engagement, crowning, restitution, external rotation. What are the causes of non-immune hydrops except? So see, non-immune hydrops causes are very important, important for all type of exams. Very important. This is a chart from the Williams. Okay, they have asked from infections. Immune hydrops is mainly by Rh negative pregnancy. For non-immune hydrops, you have hematological causes, syndromes that are associated, chromosomal causes, malformations, infections. But infections, they have it's a area of question. See, what are the options? What are the parvovirus B19 should remember syphilis under the torch, toxoplasma, CMV, herpes simplex virus, rubella, varicella, hepatitis A, Coxsackie virus, RSV, listeriosis, Chagas disease, Lyme, enterovirus, leptospirosis. So under this, HIV is not given. So option here it is HIV. Okay. Even in HIV, we would have seen, see, non-immune hydrops is not seen in HIV. Okay. That's also straightforward, easy. If you see the options, that is a very striking option here. See, they've asked about the placenta previa and placenta abruption. I think, again, I didn't get the complete answer for this. I mean, options. It's again an incomplete questions. But coming to the discussion of placenta previa, the risk factors of both, but how do they present, how are they different? Most commonly, their placenta previa is a painless recurrent causeless bleeding, and they often present with pallor, uterus with non-contraction, present with malpresentations. Why? Because the placenta is going and sitting in the lower pole, so the baby keeps on rotating, so that the head will not be occupying the lower pole, so there is malpresentation. Fetal heart sounds are usually heard. Investigation of choices, transvaginal ultrasound, and expectant management. They will ask a lot of questions from expectant management, that is called the McCaffin regime. And active management is nothing but the termination of pregnancy. Coming to the placental abruption, remember trauma is a very, very important risk factor. Followed by that, you have the preeclampsia. Questions will be framed around this trauma, preeclampsia. And PPROM twins, there is sudden rupture of membranes in a twin leading to a placental abruption. It can be a concealed type or revealed type. How are they present? They present with severe constant abdominal pain, with bleeding, with general condition out of proportion to bleeding, tense and tender abdomen, that is called the Woody heart, concealed or the uterus size is larger, fetal distress on CTG, and absent fetal heart sound. Which is the most important complication is DIC. What is management here? See, never wait, no tocolytics, resuscitate the patient, mode of delivery, cesarean section if there is a fetal distress or consumptive coagulopathy. Vaginal delivery can also be done in placental abruption provided the fetus is dead and there is no active bleeding. Okay. Another, they have asked on this, I don't know, it's very sure whether they've asked from, it's not going to be the same images. One day from the students I got is the marginal placenta. Marginal placenta is the abnormality of the cord insertion. Normally it inserts at the center. The marginal placenta, where it's inserts at the margin of the placenta, which is also called as the battledore placenta. Another question they've asked from the succinturate lobe, where there is additional lobe. There is a small lobe that is away from the main part of the placenta, that is called succinturate lobe. This is, again, this is not the same image, but questions are, that's what I said, there are a lot of questions from placenta, from the basics. That's very nice. So it's easier to understand also. So this is all about the questions. And coming to the analysis, how was the paper? See, there were some 5 new questions they have asked. Otherwise, another 80% of the questions are from previous paper. Even the new questions they've asked, the options were relatively easier, and it was some options were so obvious, and I think this exam was better compared to the previous exams. Even then, you feel it's little difficult for you, not to worry. The obstetrics had a very few weightage comparing to the other subjects this time. That's all for the session today. Thank you.